Hey everyone, and welcome. If you're getting ready for the NCLEX, you know delegation questions are coming for you. They're a sure thing. And honestly, knowing how to properly delegate to unlicensed assistive personnel, or UAPs, is one of the most critical skills you need, not just for the test, but for being a safe nurse. So in this study guide, we are going to break it all down, the do's, the don'ts, and the oh no you didn'ts, so you can walk into that exam and nail those questions. Let's get into it.
So, here's our game plan. First up, we'll talk about the players and the stakes, basically who's who and why it matters so much. Then, we'll get into the nitty-gritty of the UAP's scope of practice. After that, we'll walk through the 5 rights framework, which is your go-to safety checklist. Then we'll zero in on the single most important factor, patient stability. Finally, we'll pull it all together with some NCLEX strategies and end with a little clinical judgment challenge to test your skills. All right, first things first, before you can even think about delegating, you have to know exactly who you're working with and, more importantly, where your responsibility as the RN begins and ends. Getting this foundation right is, well, it's everything. So who are we talking about when we say UAP? Well, these are the indispensable members of our team who help with fundamental patient care. You know them as CNAs, patient care techs, or nurse aides. But here is the single most important part of that definition. They do not hold a nursing license. And because of that, they work under our supervision, the RN supervision, which puts all the accountability squarely on our shoulders. Okay, listen up. If there is one thing you burn into your brain from this entire explainer, this is it. This is the golden rule. Delegation does not, I repeat, does not equal giving up responsibility. When you hand off a task, you are not handing off the accountability for that patient. You, the nurse, are always the one ultimately responsible for the patient's outcome. This is a huge NCLEX trap, so don't fall for it. Okay, so let's get practical. This is where the rubber meets the road. Knowing what you can and absolutely cannot hand off to a UAP is the core of what the NCLEX is going to test you on. So what's in the UAP's wheelhouse? Well, for stable patients, and that's a key word, stable, they can totally handle routine, predictable care. We're talking about activities of daily living, or ADLs, like bathing, feeding, helping patients to the bathroom. They can help with ambulation, repositioning, and they are fantastic at gathering data. They can measure vital signs, record I's and O's, get daily weights, and transport patients. Their job is to collect the data. Our job is to figure out what that data means. And here's the other side of that coin. This is the red flag zone. And you can bet it's all over the exam. A UAP cannot do anything that requires the nursing process. That means no assessments, no clinical judgments, no administering meds, no sterile procedures, and absolutely no patient teaching. They can't interpret vital signs or care for unstable patients. Basically, anything that requires critical thinking is off-limit. Here's the simplest way to remember it, and honestly, this little phrase will save you so many times on the exam. Just ask yourself, does this task require clinical thinking, judgment, or evaluation? If the answer is yes, then it belongs to the RN. Period. No exceptions. So, how do you make the right call every single time without fail? You don't just guess, you use a framework. Let's go through the 5 rights of delegation. Think of this as your safety checklist, not just for the NCLEX, but for your entire career. Okay, let's break it down. First, is it the right task? Is it something routine, predictable, and low risk? Second, is it the right circumstance? We'll dig into this more, but it really boils down to, is the patient stable? Third, is this the right person? Is this particular UAP trained and competent to do this specific task? Fourth, did you give the right direction and communication? You can't just say, go check on room 4. You have to be specific and clear. And finally, number 5, right supervision and evaluation. You have to circle back, monitor the situation, and evaluate the outcome. For delegation to be safe, you need a yes on all 5 of these. I know we just mentioned this in the 5 rights, but patient stability is so incredibly important that it gets its very own section. This is the absolute, non-negotiable gatekeeper for all delegation decisions. Let me just ask you straight up, because it's that crucial. When you're staring down an NCLEX delegation question, what is the very first thing you should be looking for in that patient scenario? The answer is patient stability. A stable patient is predictable. Think of someone with a chronic condition that's well managed, or someone whose outcome is totally expected. There are no sudden changes. An unstable patient, on the other hand, that's a whole different story. This is your new admission, someone with post-op complications, a sudden change in their condition, or funky vital signs. Any little hint of instability means that patient is yours and yours alone. No delegation. All right, theory time is over. We've got the rules down. Now let's apply them exactly how you're going to see them on the NCLEX. This is where we connect all the dots and turn knowledge into points on the exam. Okay, let's look at some classic scenarios. Can you delegate getting vitals on a stable COPD patient? Absolutely. But assessing their pain after you've given them medication? Nope, that's evaluation. That's RN territory. How about feeding a patient who has no trouble swallowing? For sure. But teaching that same patient how to use their incentive spirometer? That's teaching, RN only. You see the pattern, right? The tasks on the left are about doing and collecting. The tasks on the right are about thinking and evaluating. All right, time for a quick practice check. Which of these tasks can the RN delegate to a UAP? Let's go through them. A. Assessing long sounds? Nope, that's assessment. B. Teaching a new diabetic? Nope, that's teaching. D. Evaluating a patient's pain? Nope, that's evaluation. That leaves us with C. Obtain a daily weight on a stable heart failure patient. Is it a routine task? Yes. Is the patient stable? Yes. That is a perfect task to delegate. So let's boil this all down into your high-yield exam pearls. These are the things you absolutely must remember. UAPs collect data, RNs interpret it. You only delegate to UAPs for stable patients. They cannot do any assessment, teaching, or evaluation. The RN is always accountable for the outcome. And here's your ultimate safety net. When you're in doubt, just do it yourself. It's always the safest answer. And here are 2 little memory anchors I want you to repeat in your head during the exam. First, UAP equals routine, stable, predictable. And second, our golden rule, delegate tasks, not responsibility. These phrases will keep you on the right track when you're under pressure. Okay, it's time for our final challenge. Let's wrap this up with a next-gen NCLEX style scenario. The NG-N is all about clinical judgment, and delegation is a huge piece of that puzzle. This is where you have to synthesize everything we've just talked about.
So here's the situation. You have a patient, they're 12 hours out from a knee replacement. Your UAP comes to you with a new set of vitals, BP 145/90, heart rate 105, respirations 22, O2 at 94%. Now, the most important piece of information in that whole scenario is the last sentence. The patient's previous vitals were stable. That tells you this is a change. This isn't their baseline. That's your red flag.
So the UAP asks you, hey, should I still go walk the patient like we planned? Now, you know the answer is no, but that's the easy part. The real question is, what do you, the nurse, do next? Given this change in condition, this sign of instability, and your total accountability for this patient, what is your very first, most critical action? Think about it. That right there is the kind of clinical judgment that separates a good nurse from a great